Hello, my name is Justine Latif, and I am a P3 student at the College of Pharmacy and Pharmaceutical Science. For my research of an article, I looked up the article ezetimibe added to statin therapy after acute coronary syndromes. This was a study funded by Merck. It was conducted within the years of 2011 to 2015. The objective of the study was to see the benefit of adding ezetimibe to simvastatin therapy of lowering LDL levels in patients who have had an acute coronary syndrome versus patients who have simvastatin alone. This trial was a double-blind randomized trial. It was monitored by the Data and Safety Monitoring Board, which consisted of thrombolysis and myocardial infarction study group and the study sponsor, which was Merck, in addition to the Duke Clinical Research Institute. The total amount of patients that was involved in this study was about 18,000 patients. They were randomized at several sites across the globe, primarily in America, but they wanted to see the diversity and the ethnicity of each ethnic group and race and see how the statin therapy with ezetimibe would affect it. About 9,000 patients of the study were assigned to the simvastatin monotherapy group, which was just given simvastatin by themselves, and about another half, which was about 9,000, were also assigned to simvastatin in addition to ezetimibe. They were assigned to the random groups in July 2011 through October 2015. The database, though, was locked in October 21st, 2015 to ensure all the patients were going through with their therapy, and the research was closed in by then. The location, as I mentioned, was primarily in North America, but it also took place in Western Europe, Eastern Europe, Asia Pacific, and South America. The inclusion part of this trial, they allowed either gender, but they had to be at least 50 years of age. Patients who had been hospitalized with within the preceding 10 days for an acute coronary syndrome were also included in this trial, and the acute coronary syndrome had to consist of either an acute myocardial infarction with or without ST segment elevation or high-risk unstable angina. Their LDL cholesterol level had to be 50 milligrams per deciliter or higher, and the maximum LDL cholesterol level for those not receiving long-term lipid-lowering therapy had to be 125 milligrams per deciliter. However, for those who were not receiving long-term lipid-lowering therapy, their maximum LDL cholesterol level had to be 100 milligrams per deciliter. Patients who could not participate in this trial or in this study consisted of patients who had a CABG after their acute coronary syndrome, those who had a creatinine clearance of less than 30 milliliters per minute, those with liver disease, or those using statin therapy that had LDL lowering potency greater than 40 milligrams of simvastatin, because that was the strength of simvastatin that was used in the trial. So as the trial began, the patients were each given or assigned double-blindedly to their to the two arms of the trial. They were either assigned to a group which took simvastatin along with a placebo pill, or simvastatin with ezetimibe. Simvastatin was initially given at 40 milligrams for both arms, and ezetimibe, for those who were taking the dual therapy, was given at a dose of 10 milligrams. Like we said, it was pretty much for those who have had a acute coronary syndrome and those who had who wanted lipid lowering therapy. During the study, those who would follow up with the those who continued with the study but then discontinued were followed up through telephone calls. However, the patients who did continue with the study would have follow-up visits every 30 days. and then 4 months after those 30 days, and then they would continue every 4 months after that. Blood samples were also randomly given or taken at the first month, 4th month, 8th month, and 12th month. Afterwards, they were given or they were taken every year for those who attended the clinic visits, for those who continued with the therapy. For the patients who had LDL cholesterol levels higher than 79 milligrams per deciliter on 2 consecutive measurements had an increase in their simvastatin dose to 80 milligrams. However, it was in a double-blinded manner. Neither the patient nor the physician administering the drug knew that the dose was increased. And any patient who was previously taking 80 milligrams of simvastatin before the trial for less than 1 year had their dose reduced to 40 milligrams due to a new FDA guidance which was released in 2011, and it limited the amount of 80 milligrams of simvastatin prescriptions released. However, if the patients were previously on the 80 milligram therapy of simvastatin and their LDL cholesterol levels were higher than 100 milligrams per deciliter, the study drug was discontinued and they would put the patient on a higher therapy. And the study continued until each of the patients had been followed for at least 2.5 years, and until they reached their target number of events, which was 5,250 acute coronary syndrome events. The primary endpoint consisted of a composite death from cardiovascular disease or a major coronary event. This could consist of non-fatal myocardial infarction, documented unstable angina requiring hospital admission, or coronary revascularization occurring at least 30 days after randomization, or non-fatal stroke. They were assessed from the same time of randomization until the first occurrence of one of those events. The secondary endpoint was the composite of death from any cause, major coronary event, or non-fatal stroke, composite of death from coronary heart disease, non-fatal myocardial infarction, or urgent coronary vascularization 30 days or more after randomization. For the follow-up, during the study, the patients would have to follow up, as I mentioned earlier, every 30 days, and then 4 months, and then 4 months after. And like I said, those who discontinued the study in the middle of the in the middle of the study would be given telephone calls to see how their therapy was going, either if they were continuing or why they discontinued, whether if it was due to side effects or whatever it was that caused them to discontinue the therapy. As I said previously, the study was about 2.5 years for each patient, and they kept following patients until they reached their target number of 5,250 acute coronary syndrome events. The two arms, as mentioned, were the patients receiving simvastatin plus the placebo group, and these were also called the monotherapy groups, as well as those receiving simvastatin, and the other arm was those receiving simvastatin and ezetimibe. For the statistical analysis, the 50-50 events would be needed to give the study a 90% power to detect a 9.375 lower relative risk for the primary endpoint. All efficacy and safety analyses were performed in the intent-to-treat population for those who had acute coronary syndromes or needed a decrease in their LDL levels and have had a previous cardiac event. The Data and Safety Monitoring Board conducted 10 safety reviews, and the board members were mentioned earlier. The false positive error rate for the 3 secondary endpoints was controlled with the use of the Hawkbird method. Data for the analyses were based on the database. It was locked in October 21st, 2015, as mentioned earlier. And the events, the event rates were Kaplan-Meier failure rates at 7 years. For the results, the baseline characteristics were were well matched throughout the entire study. The average age was about 64 years old. 24% were women. 27% had diabetes, And in this study, they had a mix of different comorbidities. It wasn't solely for those who had ACS and high lipid levels. It was for everybody: diabetes, hypertension, whatever it was, all those patients were accepted into this study. 88% had undergone coronary angiography. 70% had undergone a PCI during the index hospitalization. 34% were on statin drugs at the time of the index event. 77 received statin therapy during hospitalization. So we can see that there's there's an increase in statin therapy, so we're trying to see, maybe if ezetimibe helps afterwards. The simvastatin was increased to 80 milligrams for elevated LDL cholesterol levels in only 27% of the patients in the simvastatin monotherapy group, and it was even less in those receiving simvastatin and ezetimibe at 6%. So that was a pretty good difference. You can see that ezetimibe really made a big difference. The number of patients who discontinued the drug were about 10%, and after the median of 6 years, 42% of the patients in each group had discontinued the study medication without having died or without having had a primary endpoint. The primary endpoint was pretty much Kaplan-Meier event rates for the primary endpoint at 7 years consisted of 32% in the simvastatin ezetimibe group and 34.7% in the simvastatin monotherapy group. And we could see that the benefit appeared after about a year. The secondary endpoints, as for those, the rate of each of the secondary endpoints was significantly lower in the simvastatin ezetimibe group rather than the simvastatin monotherapy group. The death rates for the cardiovascular cause in any of the two groups were pretty similar. There wasn't any significance in one group or the other. The risk of myocardial infarction and ischemic strokes, however, were significantly lower in the combination group rather than the monotherapy. There wasn't a big significance in the hemorrhagic stroke for either of the two groups. The rate of the major vascular events, as defined as the CTT, was also significantly lower in the combined medication group, their medication therapy group. Discontinuations of study medications owing to adverse events occurred in only 10% of those with the monotherapy and 10.6% of those in the combination group. Common adverse effects were common in both groups, or it was about the same rate in both groups, and they consisted of an ALT or AST greater than 3 times their upper limit, gallbladder-related adverse effects, rhabdomyolysis, myopathy, myalgia with creatine kinase elevation greater than 5 times the upper limit values. For the author's conclusion, ezetimibe was added to statin therapy, and as a result, there was an incremental lowering of LDL cholesterol levels and improved cardiovascular outcomes. Furthermore, lowering LDL cholesterol to levels below the previous targets provided additional benefit to those who previously had an acute coronary syndrome. Some of the strengths that I noticed in this trial was that it was double-blinded and randomized. It consisted of a lot of patients, 18,000 patients. They had approximately half doing the combined therapy, another half doing the monotherapy, and it also had different racial backgrounds and coexisting conditions such as diabetes, hypertension, and chronic heart failure. The duration was about 7 years, so it allowed us to see the long-term effect of the drugs for those who started in the very beginning. And it gave us an efficient description of primary and secondary outcomes. However, the weakness was that it was only simvastatin use, so we didn't know how other statins would work, and it was only for the patients who had previous ACES. It was an interesting therapy to learn about, specifically since we just learned about chronic heart failure and acute coronary syndromes and lipid therapy. So it was great to see how ezetimibe added a benefit to those who had previous acute coronary syndromes. Thank you for listening.